Oh, thank you so much.
I'm Hong Chang Luo. Okay, the topic of my presentation today is the application of contrast enhanced voiding isotherapy in children with vesical retinal reflux. Right now I'm in Wuhan, China. As you all know, the vesical retinal reflux, we can call it VUR, refers to a condition in which urine flows from the bladder back up the ureter and even back into the kidneys. Definitely VUR is a risk factor for urinary tract infection, and the incidence of VUR is much higher among children with VTI. It definitely is depending on age. It's 30 to 50%. The prevalence of VUR in normal children has been estimated at almost 1%. The female to male ratio is 6 to 1, while boys typically have higher grades than girls. Definitely on some hereditary components. If the sibling of children with VUR, they have very high possibility to have it. The possibility is almost 27. And if the parents have the VUR, I think the children have almost 35% possibility to have it. Fortunately, I think most of VUR can decrease with age. So for the etiology of the VUR, there are two kinds of them. First is the primary and second is secondary. I think the primary VUR is the defect of the functional valve between the bladder and the ureter that can normally close to prevent urine from flowing backwards. This is the majority of the VUR. But for the secondary VUR, is usually a blockage in the urethra. Sometimes it comes from surgery, injury, recurrent infection, or abnormal pattern of emptied bladder, or sometimes it comes from the past infection that had put pressure on the bladder. So if the children have the VUR, sometimes they have some clinical features, but most VUR children, they have no symptom. But if they have some urinary tract infection for a long time, it will lead to kidney scarring, high blood pressure, sometimes will lead to kidney failure. And for the treatment, first we can choose antibiotics and the difflux injection, and definitely finally we can choose surgery. For the key points of the VUR therapy, first is protecting renal function is the key goal of the therapy. And in order to diagnose and the management of the VUR, the image examination is very important. So in order to diagnose the VUR, definitely we can use some laboratory tests, for example, blood test, urine test, and some other tests for the renal function. But in order to diagnose it, I think the image examination is the most important. In the past, I think most doctors use voiding cytorecytogram. We can call it VCUG as the golden standard. And definitely some other doctors use radionuclide cystogram, abdominal ultrasound, urodynamics, and contrast enhanced voiding isotherapy. I can call it CEVUS is what I want to introduce today. So for the efficiency of CEVUS, we can compare it with the VCUG, which we used in the past as the golden standard. The reflex detection rate using CEVUS was higher by 9% compared to VCUG, and 70% of reflux missed at the VCUG and just detected in CEVUS were higher grades. And in a recent meta-analysis and comparative studies of CEVUS with VCUG as a reference method, the sensitivity is 90% and the specificity is 92%. For the safety of CEVUS, and we know CEVUS is suitable for children of all ages, a range from newborn to 18 years. No none of the sentence reports adverse events potentially related to the CVUS in children. All the adverse events were transcendent and included dysuria, hematuria, and urinary intention, urinary tract infection, and blood discharge, perineal irritation, and some other discomfort. But as we all know, the known adverse events just contribute to the bladder catheterization, not rather rather than to the contrast agent. So it's not associated with the contrast agent. It's just because of the bladder catheterization. So definitely right now, we can find a lot of advantages of CVUS. For example, it's high sensitivity, real-time dynamic observation, can detect the higher grades of reflux than VCUG. And there's no need for sedation, no radiation, and parents can accompany with the children. So because of the advantage of the CVUS, so according to the long labor guidelines that published in 2017, they in 3 conditions, the recommendation grade of the CVUS is the highest the recommendation grade. So the first is the initial examination for suspected VUR in girls. It's just right here. And the second is the follow-up of the VUR in girls and boys after conservative and surgical treatment. And the third one is the screen high-risk patients for reflux. In these 3 conditions, the recommendation grade is the highest grade. But if for the boys, especially the initial examination for suspected VUR in boys, I think the recommendation grade level is level B. So in order to finish CVUS, definitely there's something we need to do before the test. First, definitely is the written informed consent. And I think some children need antibiotics prophylaxis. We need to estimate the bladder volume. Typically, most of the time we use this formula is the age plus 2 and multiply 30 milliliter to estimate the bladder volume. So for the requirements for the technique, we need some high-end ultrasound scanner with dual images display and no mechanical index, and the second generation ultrasound contrast agent. Right now in China, we just use SolarView as the contrast agent, and 5F or 6 to 8F catheter are the saline solution and some other stuff. Usually, if we want to fish CVUS, we need 3 persons, 2 technologists and 1 radiologist. So for the CVUS, there are some procedures to perform. First, we need to insert the catheter and empty the bladder completely. And we need to inject the warm 1/3 volume saline solution. And we need to inject 1 to 2 milliliter contrast agent into bladder through catheter, and connect the catheter to a venous infusion line connected to the bed with 500 milliliter of saline solution. And finally, we can use the manometer to supply a sustained pressure of 70 millimeter hydrogen. I think in my hospital, we just can place the bag with the saline solution almost 80 centimeter higher than the examination bed and not use the manometer. So it should be just for simple. And for the image procedure, first we need to intermittently check the bladder during the feeding phase. Alternated scanning between right and left kidney during and after feeding. Evaluate the urethra through transperineal approach and suprapubic, placing the probe in a sagittal plane in boys and girls. I think there are some serious feeding, 1 or 2 repeated rejection with intermittent boiling. After that, we can just slowly remove the catheter, reevaluate your urethra during voiding. As we already know, the entire CVS time is almost 15 to 30 minutes. I think from the pages, from the pictures we find right here, the left picture is the bladder filled with the contrast agent and saline solution. And the second one is the show the I think the dilatation of the collecting system and the ureter. And the third one is shows after the voiding, we can evaluate the urethra through transperineal approach, figure out the bladder and the urethra. And after the last voiding, we can check the bladder and figure out whether there's how the bladder looks like and how is there some residual urine in the bladder. So according to the VCUG grading system, we can figure out the grading system of CVUS. From the left to the right is from grade 1 to grade 5. For the grade 1 of the CVUS is the reflux does not reach the renal pelvis. It's very decrease of urethral dilatation. From right here, we can figure out there's not any sign and the reflux do not reach the renal pelvis. We can just show the ureter. So for the grade 2, I think grade 2 is a reflux reach the renal pelvis, no dilatation of the connecting system. Usually it's the normal phonesis. Right here for this video, we can figure out that we can show the collecting system, but the collecting system is not. I think for the grade 3 of the CVUS is the mild or moderate dilatation of the ureter with or without kicking. Moderate dilatation of the collecting system usually is normal or minimal deformed phonesis. We can figure out this is grade 3. We can see the collecting system is a moderate dilatation, but we can figure out the phonesis is still normal right here. For the grade 4, the CUS is the moderate dilatation of the ureter with or without kinking, or moderate dilatation of the collecting system, blunt phonesis, but we need to figure out the papillary impression is still visible. So we can figure out the collecting system is absolutely dilatation, but right here we can figure the papillary impression is still visible, so it's a grade 4. For the grade 5, is gross dilatation of the kinking of the ureter, marked dilatation of the connecting system. The papillary impression no longer visible. Sometimes we can find intraperitoneal reflux. So right here we can figure out I think the collecting system is marked dilatation. And most important is that the papillary impression is no longer visible right here. So this is the grade 5 of the CEVUS. I think I can give you an example. It's a very little girl. She's just 7 months old, and he had a fever for 2 days. The highest temperature is 38 centigrade, and the urine white cell is negative or positive. And most important, we can figure out the blood white cell is much higher than normal. When we check the left kidney, we can figure out is the moderate dilatation of the connecting system, but we can see the phonesis is still normal right here, so we can give the grade 3 for the left kidney. When we check the right kidney, as in compared to the left one, the creatine system dilatation is I think is more marked, and but I think the papillary impression is still visible. So for the right kidney, I think the left grade. For the right kidney, I think the grade is grade 4. So I think this little girl and her left kidney is 3 grade, and the right kidney is the 4th grade. So I think maybe first she needed some antibiotics. If it don't work, maybe finally she needed some. And for the summary, as a contrast enhanced voting ultrasonography, CVS is an alternative radiation-free method with sensitivity and specificity in the diagnosis of VUR comparable with VCUG respectively. And I think it has the ability to depict the anatomic structure of the urethra. So thank you so much for your attention. Yeah, this is the picture of panda. I hope you can enjoy my presentation. Thank you so much.
Thank you very much, Dr. Liu. Are there any questions? I have one question here.
Yeah, I think you're right here.
There's one question from Damjana Kluchevich. The dose of SonoView is much too high. 0.5 milliliter is enough. Why do you use such a high dose? It's a question from the audience. So the question
Excuse
is,
me, sorry.
Yeah, the question is, why do you use more than 0.5 mil of SonoView?
Yeah, it depends, you know, it depends on sometimes, you know, if I just use the 5 view or 6 view, it's not big enough, because when the bladder is filling with the saline solution, it's if the bladder is not completely full, it can automatically come out. So in order to just make the bladder completely full, sometimes I use the 8 view, but it's just a minority of the minority situation. Most time it's just a 5 or 6 view.
Okay, thank you. I have another question. It's from myself. Do you mix the water, the saline and SonoView before you inject it, or you inject water and then you add SonoView?
I think first I inject 1/3 volume solution, just according to the before the procedure I estimated the volume, and after I inject the 1/3 volume the saline solution, and then I inject 1 or 2 millimeter concentration just direct into the bladder.
Okay, thank you very much. So, and thank you for your presentation, and thank you for the question. I think we'll move on now to the next speaker, who is...
Thank you so much.
You're welcome.